Welcome to another episode of Judgment Date. We have, as you know, been dealing with a whole range of issues which have followed the unprecedented COVID-19 pandemic, the medical issues, the legal issues, the economic issues, and from time to time we've branched beyond that. And I would have thought, I would have hoped that by now perhaps we could have moved on, but alas, that isn't the case. And I'm incredibly privileged to again be able to talk to Professor Shabir Madhi, Dean of Medicine at Wits, who's one of our leading experts in COVID-19 and who's been extraordinarily generous with his time. I think this is the third time that I've interviewed you, and I just want to thank you again, because I think the public just appreciates the contributions you make, and certainly I have found them unbelievably elucidating. So perhaps could I start, Shabir, by asking you, where are we now? I mean, I'm living in a part of the world where it seems that infections are on the rise.
So good afternoon, Dennis, and thank you for having me again. I really enjoyed the thought-provoking question.
No. And you make me feel...
I think, as you correctly point out, where we are in South Africa currently is there's the real making of a resurgence that's currently taking place in the Eastern Cape and also starting in the Western Cape. And unfortunately, reports over the weekend and the few reports that have been filtering through yesterday and today indicates that even in KZN, because of us engaging in activities that simply shouldn't have been allowed at this point in time, there's a high likelihood that we're probably going to start experiencing a resurgence in KZN much earlier than I would have otherwise anticipated. So South Africa simply is not out of the woods. A large percentage of the adult population in urban areas were likely infected the first time round with the first wave of the outbreak. But the percentage that were infected is too low for there to be sustained interruption in terms of the chain of transmission of the virus. It's probably about 30–35% of adults that were infected. But that only brought the epidemic down or caused that particular wave to subside because of people. Even though there wasn't 100% adherence, there was some adherence to the wearing of face masks, avoiding overcrowded settings in poorly ventilated areas, and physical distancing. Once you remove those sort of NPIs, the non-pharmacological interventions, if you allow the virus to continue transmitting, you're going to get the resurgence that's currently been experienced. And all indications are that come February next year, we're probably not going to be much better off than where we were in round about May, June of this year, in that we're going to see a resurgence across the country if behavior is allowed to continue the manner in which it is currently existing.
So can I ask you on that? I mean, forgive me for cynical. I mean, I understand that people like yourself and your colleagues, and in fairness, the president and others, you know, seeking to encourage people to wear masks and to socially distance and do the sensible things. But it does seem to me that a very significant percentage of the population just won't listen. Now, given what you're saying, that we could be back to where we were in May, June, how does one deal with that?
Look, so I don't think there's avoiding people getting infected in South Africa. And we're going to get some sort of resurgence sooner or later. That is going to happen. The big issue is being able to manage the magnitude of the resurgence, and in particular, how many people get infected over a short period of time. So there is COVID fatigue. People are getting tired of hearing the same message. People are getting tired of physical distancing, social distancing, wearing a face mask. But when you look at experience in the United States and a number of other countries now, what is clearly evident is that more than 80% of infections that are taking place because of the super spreader events. And included amongst the super spreader events are the type of rage parties that were held in KZN last week. It includes indoor dining in poorly ventilated areas. It includes even 50% occupancy in places of worship where there's poor ventilation. So I'm not saying that people should wear a face mask 24/7 or when they're outdoors, but certainly what we shouldn't be allowing to be able to sort of manage or prevent the super spreader events is we simply shouldn't at this point be allowing mass gatherings, especially indoors in poorly ventilated areas. when it comes to the face masks, I think the reality, as you mentioned, is that probably 70, 80% of the population, when they're in public spaces, when they're out in the open, are not wearing a face mask. And that is the reality we need to live up to. And I don't think we're going to be able to change that behavior. I think we need to become much more focused and targeted in our messaging. And we need to understand what our end game is, what our objective is. Our objective cannot be to prevent people from getting infected. That is going to happen unless we had a populace such as in South Korea, where everyone wears a face mask in public. Those infections are taking place and they will continue taking place. But again, what we're wanting to do is safeguard our healthcare systems from being overwhelmed. And the way to do that is to basically avoid situations that leads to many people getting infected over a short period of time and getting this massive resurgence, rather than one that is drawn out over a longer period of time.
Does that then mean that I know even early on you were against the lockdown. It's obvious that we can't have that now because it would be disastrous for all sorts of, but are there measures, some restrictive measures that the government should be taking now? Or is there nothing that they can do?
Gatherings in indoor spaces of even more than 20 people, that activities that simply shouldn't be allowed. And it should never have been allowed even at level 3, when government started to allow 100% taxi occupancy and started to allow indoor dining. Those sorts of activities simply shouldn't have been allowed. So it's really about this gatherings in indoor spaces, especially where there's poor ventilation, even if people are wearing face masks. That is not going to help under those circumstances.
And nightclubs and pubs?
That's a complete disaster. Nightclub, pubs, and shebeens. When I'm talking of indoor dining, perhaps I'm being too specific, and that's just an example.
So I was just thinking about my tucking in at a restaurant. Yeah.
No, certainly. I think especially in this settings where the resurgence is taking place. Again, as an example, saying that there's going to be an alcohol ban from 10 o'clock, or people are only going to be allowed to purchase alcohol until Thursday. That is going to have a negligible effect in terms of the trajectory of the resurgence. If you still continue allowing people in mass gatherings, if you still allow people to go to places of worship with 70, 80, 90% occupancy. And just last week, I went to a place of worship and I had to raise objections that what was taking place there simply was not what is required of us as citizens, as responsible citizens. So it's behavior change, it's understanding, and it's also being pragmatic. I'm not saying that South Africa shouldn't go on vacation. People need to have fun. It's been a hectic year for many, many people, but it's about responsible behavior. And the one thing that we can do, which won't impact to a major extent on the economy, on the life, and on the activities of people, is to try to avoid these overcrowded settings.
So what about outdoors? I mean, obviously we're going to have very crowded beaches and other gatherings. I mean, is that dangerous, or is that, will people be okay?
That would be, I wouldn't say perfectly fine. I was about to say perfectly fine.
No, of course.
But those sort of activities are much easier, are much more safe than indoor activities. I remember what we now understand of this virus, which we didn't understand right at the start of the epidemic, and probably not until 3 to 4 months ago, is that most of the acquisition of this virus is through airborne transmission, and especially the virus particles that remain suspended in the air, even for hours in poorly ventilated areas. And that's how most people actually become infected, rather than a person touching a contaminated surface or a person having a casual interaction with someone else for less than 15 minutes, less than 10 minutes. So where in open door spaces there's good ventilation, the virus does not hang around. The virus simply dissipates in the air, and the chances of inhaling infected air in open spaces is nominal. So we need to move as much activities, even if people want to go to church, those activities need to take place outdoor. That's a safe environment. You're allowing for things to happen, but at the same time, you're not putting people at risk of being infected, especially over a short period of time.
So like, for example, restaurants, I mean, in the summer months, there's no reason why, with some imagination with regard to even the roads, if one actually gave people some extra space, the restaurants could have their people could dine al fresco. On your line of argument, that becomes a lot safer than having people indoors.
Without a question, that's exactly what the restaurants need to do. They need to move all of the activities outdoors wherever it's feasible. And if it's indoors, those windows need to be open. Even if the weather might be a bit cool, those windows need to be open. You need to ensure adequate ventilation. People are not going to wear a mask in the restaurant. It defeats the purpose of going to a restaurant. But there needs to be adequate ventilation.
So let me ask you this then. I mean, are you guys in the medical profession, are you getting better at treating people with COVID?
So we much more knowledgeable in terms of how to improve outcomes of people that are hospitalized with COVID-19. And fortunately, many of the most impactful interventions are actually low-cost interventions. So things such as using steroids or using high-flow oxygen without putting someone onto a ventilator. Those don't cost much, but those are type of interventions that have really been impactful in terms of reducing the risk of someone dying after they're hospitalized. But at the same time, in South Africa, unlike the narrative that's in the public, that we've got an extremely high recovery rate, which is sort of a meaningless metric in terms of understanding exactly what's happening. When you look at people that are hospitalized for COVID-19 in South Africa, the case fatality risk is roughly about 18%, which in fact is higher than what it was in high-income countries during the first wave of the outbreak. So we've not been exceptional in terms of our management of individuals with COVID-19. Our case fatality rate is higher than the 12 to 14% that was reported in the United Kingdom and Italy and Spain during the course of the first wave. Not the new tools, but had we not understood how better to manage individuals. And like I said, there are really two things which have made a striking difference, and that is high flow oxygen and the steroids, and then obviously the manner in which the individual is nursed in the bed. And
does it obviously, I mean, on that, if I might ask, does it, just talking to some friends of mine who are doctors, if you can monitor the oxygen levels quite early on, as I understand it, if you get people to oxygen earlier on, rather than in the hopeless cases, then you've got a better prognosis.
Correct, you do. And the reason for that is, remember, all our tissues require oxygen to be able to survive. And if the tissue is deprived of oxygen for a long enough period, what's going to happen, you're going to have damage to the tissue. And hence your recovery is also going to be longer. So you probably heard of this long COVID syndrome as an example, where these signs and symptoms might continue for months on end. And much of that sequelae is probably because of hypoxia, poor oxygen delivery to the tissue, which is what we're wanting to prevent and avoid. So getting someone onto oxygen as early as possible, especially when the oxygen saturation seems to be dropping under 90%, is exactly where we need to focus. And for many of those individuals, fortunately, they can actually receive oxygen now at home. They don't need to be hospitalized. There are these mobile devices that allows us to actually manage individuals, provide them at least enough oxygen as well as steroids at home without them needing to be hospitalized.
Just on the question then of people who've had COVID, is it just anecdotal when you read about people who get it a second time? Or do we understand that at all?
Yeah, so the only thing surprising about the news that people get reinfected with COVID is that it comes as a surprise at all. And the reason for that is that it's not unique to COVID. If you look at all respiratory viruses that have been circulating, influenza is an example. People become reinfected with influenza each year. About 1/3 of the adult population will get reinfected with influenza each year. But the difference is when a person gets reinfected, the clinical cause of that illness is very different compared to the time a person gets a first infection. And the reason you've recovered from the first infection is your body has mounted an immune response. Now that immune response also induces what we call memory responses. So when you re-expose to the virus, you probably won't even know that you've been re-exposed because your body is able to mount an immune response much more quicker than the first time around and get rid of the virus, as an example. So reinfections will occur, but in terms of our experience with other viruses, and to a large extent with COVID-19, the reinfections that do occur are going to be less severe than what you experienced the first time around, because your immune system is much more active and able to mount a much more robust and timely response to that infection. So when you consider
Yes.
what's happening in Europe, in the United States at this stage, where they're getting a second epidemic and a fourth epidemic, third wave in the United States, many people have been reinfected, but the number of case reports of reinfections are few individuals, right? But many people have been reinfected, and it tells us empirically that those reinfections that are taking place are largely going by undocumented and consequently not actually resulting in severe disease.
But it does mean, therefore, that people who've been infected should still be careful.
They need to be careful because so there's two parts to it. The first part, like I said, is unlikely that an individual that has recovered from COVID is going to develop severe disease when they get reinfected. But the unknown part of it is whether that person that becomes reinfected remains infectious. And that is, he poses a risk to other individuals. So right now, we don't know whether the immune response that's mounted after an infection actually makes a person less infectious when they're exposed to the virus the second time round. So on that level, yes, people still need to be on the guard in terms of trying to avoid getting infected, simply because they might still pose a risk in terms of infecting others. And until we know the answer to that, there's studies from non-human primates, which in fact indicates that natural infection actually reduces the infectiousness of a person, of the primates, non-human primates, upon subsequent infection. So for experimental data suggests that natural infection does reduce future infectiousness upon reinfection, but in humans, the data is unavailable at this point.
So just on one final point before I get on to the whole vexed question of vaccines, when we spoke on one of our previous occasions, and I asked you about the death rates, and I think we did debate the fact that there's probably been a significant undercounting, but you also did say to me that you were doing some research, or research was being conducted to see why South Africa might have been slightly better off. And the suggestion I think you put to me, and correct me if I'm wrong, was that there might have been some other form of kind of COVID infection had taken place in larger sections of the population, so that some sort of tentative or weaker form of immunity had built up in more people than we thought. One, was I correct to understand you in that case? And two, has there been further research in this regard?
So yes, there has been further research, in fact, quite a bit of research since the last time we chatted. And all the indications are that past exposure to the common cold coronaviruses, some of which have been circulating since the 1960s, and which rarely cause severe illness in humans, but do infect humans, actually does result in immunity that is cross-reactive against SARS-CoV-2. So you do have this cross-reactive immunity. Now, whether that was the reason why the high force of infection in South Africa didn't necessarily translate into a relative equivalent high number of cases of hospitalization and death, that's still a question mark. So we've just concluded studies from South Africa where we looked at historical samples from women that we had enrolled in past studies to see what percentage of them actually had this immunity against that was induced by the common cold coronaviruses. Now, this is not peer-reviewed, so I might be slammed for sharing with you.
No, I understand your caveat.
With you in the public domain. But like I said, we'll submit it for peer review. It indicates that close to 25% of women in Soweto actually had this cross-reactive immunity against SARS-CoV-2 that was probably induced by this common cold coronaviruses. And that 25% is a substantial percentage of the population. And
why
again,
sorry, carry on.
And again, so it's the hypothesis which is most attractive to me in terms of biologically explaining this phenomena in South Africa, as well as many other low middle income countries, where this high force of infection hasn't translated into massive number of deaths from COVID-19. And that is not to say many people have not died from COVID-19, because many, many people have died, including in South Africa.
Is the suggestion then that actually in the lower income countries, there may have been a higher incidence of this than in developed countries, which would explain the discrepancy? Because whenever I put this to people, they say, well, why would people not get flu or similar forms of illness in the developed country? Is it because there's a difference?
So there is a difference, and it's not unique to this common cold coronaviruses. For many other viruses, in fact, even bacteria, the force of exposure and the force of infection in low middle income countries is much greater than the force of exposure and infection in high income countries. My background is work on a bacteria known as pneumococcus as an example. In Kenya, as an example, by 6 weeks of age, 40% of children will become colonized with the pneumococcus. In the United States and United Kingdom, it takes children to go up to 2 years of age before they become colonized with that bacteria. Children are an important vector in terms of transmission of both bacteria as well as viruses to adults. So when we look at adults as well, for this bacteria, the pneumococcus, a higher percentage of adults in low middle income countries will be colonized with this bacteria than adults from high income countries. So it's not unique. It wouldn't be unique for SARS-CoV, for common cold coronaviruses. And the same thing applies to many other viruses. So when we did studies in Soweto as well as in Zambia, looking at the common cold coronaviruses in children, what we showed is that healthy children during the winter months, 1 out of every 4 children in Soweto and 1 out of every 3 children in Zambia were actually carrying these common cold coronaviruses. And children will be transmitting this common cold coronaviruses to other individuals in that population. So it wouldn't be unique to common cold coronaviruses. It's a phenomenon for most respiratory pathogens that the dynamics of transmission are very different in low middle income, low resource settings compared to high resource settings, and for a variety of reasons.
So moving on to the vaccine, Shabir, so many questions to ask about that. But I suppose the one that everybody wants to ask is, when can we start thinking that maybe in South Africa we will get something, even if it's to start off with the health workers?
Unfortunately, this is completely within the hands of government. And this is really, they are really responsible in terms of being able to influence when we get vaccine, at what price we get vaccine, and what quantity of vaccine we would be able to get. Right now, all indications are that we're unlikely to get vaccine at least until the second quarter of next year. And even then, the quantity of vaccine we're likely to get is going to be relatively modest. Government's approach, based on media reports, is that it's largely going through the COVAX facility as a mechanism through which South Africa can procure vaccine. Now, the COVAX facility is a really noble initiative, and it's all about equity and equitable distribution of vaccine and cross-subsidization of less resource countries. But inadvertently, because of South Africa being categorized as an upper middle income country, the expectation of South Africa is that it would need to pay the same sort of price as the UK or or Canada would pay through the COVAX facility to procure vaccine. That is just the design of the COVAX facility. What that results in is that it makes it highly expensive for South Africa to actually procure vaccine, and consequently, rather than them committing to purchasing 20%, enough vaccine for 20% of the population through the COVAX facility, which was a prerequisite for participation in the COVAX facility to start off with, they've now only committed to purchasing enough vaccine for about 10% of the population through the COVAX facility. And it's all about the amount of funds that's available. Now, this shouldn't have been the case in South Africa. And it's great to show solidarity, but the reality that we face in South Africa right now is we need to speak to the economy as well in terms of what we're able to afford. And South Africa is in a fortunate position in being one of few countries that are participating in multiple clinical trials on COVID-19 vaccines. There are 4 clinical trials that were done in South Africa, 2 in my group, and 2 that's being led by other people in South Africa. That puts us in a favorable position to actually engage in bilateral negotiations with these manufacturers to be able to source vaccine at a much more competitive price than what would be expected of South Africa in terms of payment to COVAX facility, as well as to ensure that we have timely access to the vaccine in large enough quantities. So these are factors, unfortunately, which I believe government has dropped the ball. It's negotiations that should have started 6 months ago. As soon as the study started in South Africa, government should have been engaging with these pharmaceutical companies at that stage already in terms of how South Africa can be positioned to be an early adopter of these vaccines, should they be shown to be safe and efficacious in South Africa, and at what price they could get the vaccine.
Let me just get this right, because what you're telling me is extraordinary, and I'm sure everybody listening to this will find this equally important. That actually, because we participated in certain trials, we should have been negotiating on a bilateral basis to bring down the cost and get sufficient vaccine in here to essentially for I suppose, the health workers, the comorbidity people, the older people, so we don't want deaths. And you saying government has dropped the ball. It has not. We have not been negotiating.
And well, government needs to speak as to whether they've been negotiating or not.
But in your knowledge, it hasn't.
Based on my sources, unfortunately, those sort of approaches have not been made. And in fact, with the grant agreements that we've got from the Bill and Melinda Gates Foundation, as part of that grant, the manufacturers of these vaccines that we're evaluating is going to be the Serum Institute of India. And there's explicit in those grant agreements is that South Africa should actually be prioritized for gaining access to these vaccines if these studies are shown to if the studies show the vaccine to be efficacious in South Africa. So there's already sort of a framework that can be leveraged on for government to engage in this sort of bilaterals. And it hasn't happened. And the other element, which we're probably going to chat about, is not just about getting vaccine into the country. That probably is the easier of the job. Yeah. It's about actually being able to deploy the vaccine into the country.
Oh, pardon me while I scream, but let me move on. Then, what about? I mean, for example, we hear about the president went on television, not this last one, previous one, and was speaking about Johnson & Johnson and some deal that was to be done with factories here, and we've basically able to produce it in South Africa. I understood from Professor Gray that their trial is still continuing, Johnson & Johnson trial. But I mean, you're smiling, which seems to indicate that ain't going to happen.
Yeah, South Africa always super optimistic in terms of what we're able to achieve. And often we seem to fall flat but never learn a lesson. And that is the problem. So where do we stand with vaccine manufacturing in South Africa? Around about 1992, the only South Africa was one of few countries that was able to manufacture vaccine in the late 1980s, right through to 1992. Following which that facility was sort of dismantled. And then there was the public-private partnership that was established in 1994. And in the 25 years since the establishment of that public-private partnership, there simply has been no vaccine that's been manufactured in South Africa, zero, over the past 25 years. Now we've got a new role player that certainly has got a rich history in terms of manufacture of biologicals, but not of vaccines. And to expect that South African manufacturer to go through all of the loops that are required to get regulatory approval to manufacture a vaccine in South Africa over the period of the next 25 weeks, let alone the next 25 months, is highly optimistic. It's not going to happen. Vaccine manufacturing plants are not just set up. SAPRA doesn't actually have the know-how in terms of how to actually sort of regulate that sort of facilities, because they've never had to do it in the past since the MCC was in existence over the past 25 years. So yes, the manufacturing might take place in South Africa, but it's probably going to take place in 2022 and 2023. And we don't need a vaccine after the pandemic has passed. We need a vaccine while the pandemic is ongoing.
And so you're saying the only way you're going to be able to get that, we're going to be able to get that, is through essentially bilateral negotiations with those pharmaceutical companies that we've been helping to actually do the trials.
Exactly. And we, like I said, we're in a very favorable position to do that negotiations.
Well, I understand that. And I mean, I think that's, it's an extraordinarily important point that you made. What I wanted to ask you about that before we get on to distribution was that if these vaccines are approved by the Americans and the Brits and the Europeans, I mean, why would we not approve them? I read that, we've got to go through all our, wouldn't our regulatory approvals then be fairly quick if they're all agreeing to it?
Yeah. So SAPRA has been highly adaptable in terms of the approval of the COVID-19 vaccine trials, and hopefully they'll be as adaptable in terms of at least providing an emergency use authorization of vaccines that are sort of approved by the FDA or the EMA in Europe. So this is a question that needs to be posed to SAPRA, but we certainly shouldn't be trying to reinvent the wheel, because these approvals will have gone through the necessary regulatory scrutiny, and SAPRA should really piggyback onto those approvals to ensure that we don't delay the introduction of vaccine into the country. We cannot have SAPRA even spend 2 months to review these sort of approvals, simply because the resurgence is going to be very much upon us come February of next year. And in fact, SAPRA probably should be proactive. So usually what happens is that the manufacturers need to actually come with a dossier to the country, to the regulatory approval, regulatory authority for approval. SAHPRA should probably be reaching out to those manufacturers where vaccines have been shown to be efficacious and safe, to find out from them whether they're wanting some sort of conditional approval in South Africa for them to be able to bring the vaccine in the country. So it needs a change in mindset. If we don't have a change in mindset and approach, we risk only getting COVID-19 vaccines after the pandemic has passed.
And I mean, just looking at it from a point of view, if I can, I mean, I know it's not your expertise, but I mean, they are intertwined. I think everybody accepts that. The health and the economy are intertwined questions, which means that if we're going to faff around for a whole year, in fact, we're not going to get our economy to recover anyway, because we're going to have a second wave, as you indicate. People get sick, people stay off work, even if we don't have a lockdown. I mean, so so then let me, take a deep breath and then ask you this, which is, there's going to have to be a whole distributional system. I mean, this thing's not just I'm not just going to walk into Clicks or my corner grocery store and get a vaccine.
Yeah, so I mean, just take a step back. As an example, South Korea is an example of a country that has been proactive from the start in terms of this pandemic.
Which one? Sorry, yes. I didn't hear that.
South Korea.
Ah, okay, yeah.
So yesterday they announced that they've already secured deals to be able to vaccinate 50 of the 54 million inhabitants in South Korea in the next 2 to 3 months.
Wow.
Okay. We're still talking about getting perhaps 10%, enough vaccine for 10% of the population from the COVAX facility, and we're not too sure where the funding for that is going to come. So this is indicative of us not really being proactive, and that's what we simply can't indulge in right now. When it comes to deployment of the vaccine, so there are 3 vaccines, as you know, that have now been shown to be safe as well as effective in protecting against COVID-19. Of those 3 vaccines, there's only 1 vaccine that is actually deployable in South Africa, and that probably will become available. And that is the AstraZeneca vaccine. Now, I'm not saying this because I'm leading the AstraZeneca vaccine study in South Africa, but when you look at the characteristics of the other vaccines, the Moderna vaccine, which was funded by Operation Warp Speed, a condition of the US government is that Moderna can only export vaccine after the requirements of the US have been met.
Yeah. Yeah.
So it's unlikely that vaccine is going to get outside of the US at least until 2022. The Pfizer vaccine in its current formulation needs to be stored at ultra low temperatures of minus 70 degrees Celsius. Those sort of facilities outside of major academic centers in South Africa simply don't exist in the public or the private health system. So you can't actually deploy a vaccine for which you don't have the cold storage facilities to be able to store the vaccine. So the Pfizer vaccine is a non-starter at this point in time, unless it's reformulated and it can be stored at 2 to 8 degrees Celsius for a reasonable period of time. So we're left with the AstraZeneca vaccine. That vaccine, fortunately, can be stored at 2 to 8 degrees Celsius. It's stable for at least about 6 months, unlike the Moderna and Pfizer vaccine that's not actually stable for that long as well. In addition to which, the cost of these vaccines are tremendously different. So the AstraZeneca vaccine is 1/10 of the price of the Moderna vaccine. So the AstraZeneca vaccine will be coming available at about $3 to $4 per dose, the Moderna vaccine at $30 per dose, and the Pfizer vaccine at $20 per dose. So there's really, at this point in time, of the 3 vaccines, there's only a single option available to South Africa, and that is the AstraZeneca vaccine. Right? And AstraZeneca needs to be engaged. Serum Institute of India, that will be manufacturing vaccine on behalf of AstraZeneca, needs to be engaged for South Africa to gain access to that vaccine that has now been shown to be safe as well as effective in protecting against COVID.
Can I just ask you on that? Is that not the vaccine in which there are questions asked about the study, about the 3rd wave? So
the issue around that vaccine is that inadvertently what ended up happening in the clinical trial in the United Kingdom in particular is that about 3,500 individuals ended up receiving half the recommended dose as a first dose and a full strength dose as a second dose, whereas most of the other participants received 2 full doses of vaccine. And fortuitously, what happened is that they were able to do a stratified analysis. And what they found is that those individuals that received 2 full doses of vaccine, the vaccine efficacy was around about 60%. in the United Kingdom as well as in Brazil. But those individuals that received a half dose as a first dose, followed by a full dose, had a 90% efficacy. It seems counterintuitive, but this is not unique to COVID-19 vaccine. In the past, we've shown that children that get 1/10 of the recommended dose of a vaccine that protects against meningitis have got a much better booster response when they get other vaccines subsequently. So we don't know the exact mechanism, but this is where the controversy has been, that the study wasn't designed to look at this low dose and standard dose arm, but it was designed just to look at 2 standard doses. The results of this particular study, in fact, are going to be published today after having gone through peer review in the Lancet.
Okay. So can I just one final question? And what about the Johnson & Johnson one? So
I'm hoping that we will be able to get an answer in terms of the efficacy of the Johnson & Johnson vaccine early next year. It's a large study, multi-center, including South Africa, and that particular vaccine trial, in fact, is looking at a single dose of vaccine, which would be a major win. If a single dose of vaccine is able to achieve even 60–70% protection, that would be highly impactful. It's not only about the efficacy, it's about the timeliness of being able to get a vaccine, what percentage of the population are going to be vaccinated, how deployable the vaccine is, and the cost of the vaccine. So there's multiple factors rather than getting fixated as to vaccine efficacy estimates on its own.
But the take-home point is that, in fact, we're really behind the curve in terms of the arrangements, and we need to actually put the foot on the accelerator right now.
Yeah, and as a researcher, that is really disheartening. Because one of the reasons
what about somebody who needs the vaccine? I assure you that's even more so.
Yeah, I'm sure. One of the reasons I engaged in this was really to what I said right at the start, is that we can't allow history to repeat itself, as it often does, in that we don't do the clinical evaluation of the vaccine, and that usually is an excuse for a delayed introduction of the vaccine in the country. This time around, we've been at the forefront in the clinical evaluation of the vaccine, yet we seem to be delayed in terms of when it will be implemented.
I've run out of time. I suspect we'll probably, sadly enough, have to have another conversation in the new year. But again, I want to thank you, one, for all the work you're doing, and two, for your willingness to explain it to people in words of one syllable that even people like myself can understand. It's an extraordinary public act, which is so important. Thank you so much.